Pollock Chapa. He is an associate professor in the departments of internal medicine and pediatrics, as well as the Department of Epidemiology and Prevention at Wake Forest University School of Medicine. His research focuses on improving the health outcomes of low-income and vulnerable populations. He is particularly interested in addressing food insecurity and other health-related social needs, and his work is currently supported by the National Heart, Lung, and Blood Institute, as well as the National Institute of Diabetes and Digestive and Kidney Diseases. Dr. Pollock Chapa also co-directs the Wake Forest University School of Medicine Clinical and Translational Science Institute's K-12 program. He completed his training in internal medicine and pediatrics at the Massachusetts General Hospital after receiving his MD at the University of Alabama. And he also received a Master's of Science in Health Policy Research from the University of Pennsylvania's School of Medicine and completed his K-23 from NHLBI, focused on the effects of food insecurity and cardiovascular health. Thank you for being here, and take it away.
Awesome. Good? Good. Okay. Well, thanks so much for that great introduction. I didn't expect all of that, but I appreciate it. And I got the full website bio. Thank you. Thanks so much for inviting me to talk today about food insecurity and health. I was incredibly excited to get here because we had some travel issues yesterday, so this is even better to be here and see all of you. So I will get started. So just. There we go. So as Nina mentioned, I do have some grant support from the NIH, and then also have received some personal fees from one of the North Carolina Medicaid managed care programs, but won't be talking about any of that today. So to kind of give this work a little bit greater context, I wanted to start with a patient I actually saw as a resident at a federally qualified health center outside of Boston. So DB was a 6-year-old boy who was coming to me for his routine well child visit. I had been taking care of him for a few years at that point, and so had kind of gotten to know the family, I thought, relatively well. He was coming in with his mom, his 13-year-old brother, and his new 1-year-old sister. And so, at the start of the visit, I kind of looked back in the chart, saw he'd been to our clinic a couple of times for some acute visits, for abdominal pain, some headaches. And when I asked the mom, she said, well, overall, things had gotten better, but, he still occasionally got them, but didn't really seem to be too worried. And so I did my sort of usual spiel, got to the growth curves, and then I noticed that his BMI percentile had gone from a healthy weight at his 5-year-old visit to now into the overweight range. And so, I was a third-year resident. I had my spiel down about healthy eating 5 fruits and vegetables, and, I thought I had this handled. And about halfway through, his mom stopped me and said they couldn't really afford fruits and vegetables at the house. That ever since DB's younger sister was born, she had to stop working as a teaching assistant because childcare had gotten so expensive. And the family was really relying on DB's dad's salary as a construction worker. And so they were buying a lot of oodles and noodles, cheap pastas, things like that. And so she was like, so what do you want me to do? And I don't really remember what I said. I remember feeling like this. And luckily I was a resident because I'm pretty sure I just said, oh, I need to go talk to my supervising doctor, and got out of there as quick as possible. But this, DB really kind of had a profound influence on my research and career focus. But I imagine many of you have had similar situations where you had patients or study participants that, couldn't afford to have enough food at home, had to sort of miss appointments because of difficulty with transportation, or had to make difficult decisions about paying rent versus medical care. So over the next sort of 40 to 45 minutes or so, I was going to talk about kind of social determinants of health kind of quickly and a little bit more broadly, but then sort of focus more on food insecurity, its impact on health, and then spend the majority of the time kind of talking about this increasing focus around addressing food insecurity as a routine part of clinical care. And then I left some time for questions. Although we have a small enough group, if people want to stop me along the way, that's totally fine too. So I think probably many people have either seen this figure or something similar, but it looks at how much the US spends on healthcare versus other similar countries and life expectancy. And so just to orient people to the graph, if you can see it, Here along the x-axis is each of the countries with the US in this gold box. The left-sided y-axis is for the bar graph that looks at the percent of the gross domestic product each country spends on healthcare. And the right-sided y-axis is for the line graph that looks at life expectancy. And as you can see, and I'm sure is not a surprise to most people in the room, is that despite spending significantly more on healthcare, the US has worse life expectancy. Now, I could have picked any other sort of major life, metric, health outcome metric, like infant mortality, maternal morbidity and mortality, and they would also the same, that despite spending significantly more on healthcare, the US tends to have worse health outcomes than other similar countries. What may be a little less familiar to people is this figure that adds in how much each of the countries spends on social services. And for this study, they defined social services or social spending on anything that tried to lift individuals out of poverty. And the main takeaway is that the US spends not only significantly less on social services than it does on healthcare, but it spends significantly less on social services than other similar countries. And so this difference in social spending is what many people theorize is why the US has worse overall health outcomes. Now, the fact that social or economic factors impact health is certainly not a new concept. It's been around for many, many decades. But it wasn't actually until 2022 when the WHO and subsequently the CDC defined the social determinants of health as the conditions in the places where people live, learn, work, and play and affect a wide range of health risks and outcomes. Now, social determinants of health generally refers to sort of more broad social and economic factors, things like poverty, structural racism, income inequality, education, and neighborhood environment. Now, each of these factors can directly impact health, or they can indirectly impact health by affecting the distribution of individual material circumstances or social needs. So sort of more these downstream effects. And so when people talk about addressing social determinants of health as part of clinical care, they're usually referring to this, like more the social needs, because broader sort of social determinants of health require more sort of political and policy level interventions. Now, there's been a growing body of literature showing that each of these social needs also directly impact individuals' health. And one social need that's prevalent in the US and has probably have the most literature around its impact or negative impact on health is food insecurity. So food insecurity is defined by the USDA as the limited or uncertain availability of nutritionally adequate and safe foods, or the ability to acquire acceptable foods in socially acceptable ways. Now, in 1995, the USDA developed the 18-item food security survey module, which they had used to measure food insecurity rates in the US. And in 2024, 13.7% of US households were food insecure. Now, I've given some version of this talk for now more than a decade, which is kind of shocking. But it still always surprises me that even in the US, that over 35 million people are worried about where their food comes from or whether they'll have enough to buy food. Now, not all households are at similar risk to being food insecure. Particularly households with children have higher rates of food insecurity, and about almost 1 in 5 households with kids reports being food insecure. So I mentioned that the USDA developed the 18-item food security survey module in 1995, and they have been measuring the food insecurity rates in the US up until last year. And what you can see from the figure is that food insecurity was fairly steady in the sort of late 90s to early 2000s, right around 11%. And then there was a big jump in food insecurity rates in 2007, 2008 due to the Great Recession. Now, we had a slow, steady decline of food insecurity rates from 2011 down actually through the first year in the pandemic. But as you can see, it's sort of spiked back up ever since many of the economic policies from the COVID pandemic have expired. And actually, the US did quite well early on in the pandemic with many of the economic policies they put in place, which I'll touch on a little bit at the end of the talk. But since those policies expired, you have just seen this kind of steady increase in food insecurity rates in the U.S. Now, unfortunately, the current administration has decided to stop measuring food insecurity each year. So this will probably be the last year we have food insecurity rates in the U.S. for at least the foreseeable future. So we'll see. Unclear what's going to happen moving forward. So just like every household is not similar risk of being food insecure, there's a lot of geographic variation in food insecurity rates. So to orient you to the map, again, I didn't come up with these color schemes. This is from the USDA. The sort of light tan color are states that have food insecurity rates below the national average. The orange color are states that have food insecurity rates at the national average. And the sort of reddish brown color have food insecurity rates higher than the national average. So as you can see, a lot of the states that sort of in the Southeast tend to have higher rates of food insecurity. You can see Michigan is right at the national average. And now North Carolina is actually at the national average, which wasn't the case probably about 6 or 7 years ago. North Carolina actually had the 7th highest rate of food insecurity. But some of the sort of state, particularly the governor, put in several economic policies that have since actually showed some improvement in food insecurity rates. But again, many of those policies are starting to expire now, so it's unclear what will happen there as well.
Could you say what some of those policies were?
Yep. So a couple of them was, one was they did something called cross enrollment. And so essentially SNAP, Supplemental Nutrition Assistance Program, WIC, and Medicaid have similar eligibility criteria. And so the state put in a policy that if you qualify for one, then you automatically get enrolled in all three. So that got a lot of people enrolled into SNAP benefits. They also tried to strengthen some of the SNAP and WIC enrollment processes and got rid of some of the, we'll talk a little bit later, but some of the barriers to being on these programs, like re-enrollment every 6 months. They tried to make it easier for people to enroll by not having to have in-person visits to get the enrollment. You could do it online. So they tried a lot of different kind of policies like that. And they also invested a little bit more in some of the local infrastructure around food resources. Now I'll talk a little bit about some of the programming. And if we have time, I actually have a slide that I didn't include in the talk, but kept in the slide deck. If we have time, I can talk about some of the North Carolina policies around healthy opportunity pilots. So they did several different things that they tried to sort of kind of both address food insecurity, but also try to improve health. Yeah, great question. Other questions before I jump to the next section? All right. So because of the sort of recognition of the prevalence of food insecurity, kind of a clear definition of what food insecurity was and a tool to measure food insecurity, there's been a growing body of literature over the last sort of 15 years or so, specifically looking at the impact of food insecurity on health. So in this paper, actually, you'll see the authors just looked in PubMed at the number of papers that have specifically looked at the impact of food insecurity on health in the medical or public health literature. And again, what you see is sort of in 2000, there was maybe 10 papers specifically looking at that. And then there's just been this exponential growth specifically looking at the impact of food insecurity on health, up to 350 papers in 2016. And that's just continued to grow. And what we've seen across this literature is that food insecurity negatively impacts people across the lifespan and leads to worse overall health, impaired chronic disease management, and increased healthcare costs. And so regardless of what sort of population you focus on or what you work with, it's likely that food insecurity probably negatively impacts the health of the people you're caring for. So a great example is from your very own Nina Hill, who published this paper recently in JAMA Network Open that looked specifically at the association between households with a child with a chronic condition and food insecurity. And so what she did was looked at data from the 2019 to 2023 National Health Interview Survey and looked at households with children with one of 7 common chronic conditions. So it could be ADHD, autism, diabetes, prediabetes. and found that households with a child with at least one of those chronic conditions had higher rates of food insecurity overall, and you can see significantly higher rates across each year. And this was actually in a dose response. So the higher number of chronic conditions a child had, the more likely they were to be food insecure. Did I do that justice? Okay. It's always a little nerve-wracking when the author is in the audience. So why food insecurity leads to sort of worse overall health, sort of chronic health conditions is a little bit unknown. But there's sort of three sort of main kind of pathways or mechanisms that people hypothesize. The first is what's been called the nutrition pathway. And this might seem like the most sort of obvious or intuitive. So if you're worried about your limited food budget or have a limited food budget, you end up buying sort of lower cost foods that tend to be sort of higher calorie, less healthier, less likely to be fruits and vegetables. And this can lead to increased weight gain. It can also lead to other sort of diet sensitive chronic conditions like diabetes or hypertension. So like my patient DB, so, they had a limited food budget. They had to make the choice, like, do I spend it on fruits and vegetables that are healthier, but probably more expensive, or do I spend it on the oodles and noodles and pastas that, I can buy for the whole family at a much cheaper cost? The second pathway has been termed the sort of psychological or mental health pathway. And this is particularly important for households with children, and particularly impacts parents. So if parents or other individuals are constantly worried about having enough food at home, it can lead to higher rates of stress, anxiety, depression, which have all been sort of associated with worse overall health as well as development of chronic conditions. And for parents in particular, particularly for mothers, this sort of increased stress and anxiety around having enough food impacts their interactions with children. And then again, also leading to worse sort of health for the child in the home. The third pathway has been called this sort of compensatory pathway. So if you're someone living in a food insecure household, you often have to face sort of competing demands, competing priorities. So what do you spend your money on? And so families are forced to sort of make the difficult decision, do I spend money on food or do I spend it on healthcare? And this can lead to delays in people seeking necessary care, preventative care that can lead to the development or worsening of underlying chronic conditions. Now, I have this all sort of written out in these sort of nice, neat, straight lines, but you can imagine this is a lot more complicated than that. They all sort of like interact with each other and feed on each other. And just for space issues, I didn't add the part where once you've developed a chronic condition, this kind of feeds back to lead to worse food insecurity because you're having to spend money on healthcare. You're potentially missing work to go to appointments or be hospitalized. And all of that potentially leads to this sort of negative feedback loop, leading to worse food insecurity, leading to worse chronic disease management and chronic disease health outcomes. So in the US, there's at least some hope. There are several sort of federal nutrition programs specifically focused on reducing food insecurity in homes. The first is the Supplemental Nutrition Assistance Program, formerly known as the Food Stamp Program. So SNAP is the largest federal nutrition program in the hunger safety net and serves about 40 million people in the US. The way it works is that individuals who qualify receive sort of a cash benefit as part of what's called an EBT card or a debit card that they can use to purchase foods at grocery stores or in different ways. The second largest program is called the Special Supplemental Nutrition Program for Women, Infants, and Children. So the federal government provides block grants to states in order to distribute WIC funds. This includes providing sort of a food supplement, again, sort of that similar kind of cash benefit that people can use to buy for WIC qualified foods at grocery stores. It also includes funding for nutrition education as well as referral for social services. And so women who are pregnant or postpartum up to a year and infants up to 5 years of age are potentially eligible to receive WIC. The third largest program is the National School Breakfast and Lunch Program. So I think this is probably familiar to people that have kids, the sort of, or if you went to school, the people that receive sort of free and reduced price lunches, you go through this program. This also covers the summer school meals program. So many areas provide free meals to children in certain areas during the summer when school is out of session, again, to try to help with sort of that summer spike of food insecurity when kids don't have access to free meals. And the final sort of large sort of federal nutrition program is the Emergency Food Assistance Program. So this is what we think about sort of funding for food banks, food pantries, soup kitchens. Again, this was always designed to be an emergency food assistance program, although it hasn't been utilized as such for many families that have to sort of rely on this more chronically. Again, the idea is that they would have sort of an emergency place to go that if, their car broke down, they lost their job, they needed food sort of immediately for 3 or 4 days. But unfortunately, I think a lot of families have to use this more chronically. Now, despite the sort of availability of these programs, there are many barriers to families accessing these resources. So about 25% of people who are eligible do not participate in SNAP, and about 47% of people who are eligible for WIC don't participate. And there's a lot of reasons for this, certainly stigma being one, people not feeling like they want to rely on the government for benefits. But actually what I find sort of more frustrating is there's a lot of logistical barriers to these programs, both like in difficulty, like in how to complete the application, challenges with understanding the eligibility criteria. And so there's a lot of ways these could potentially be made easier, but it depends on sort of the policies around making it easier if they want people to actually sign up for many of these programs. So in the last sort of section of the talk, I want to spend a good bit of time on sort of this increasing idea of, or increasing focus on addressing food insecurity in healthcare settings. So historically, addressing food or other unmet social needs has really been the more of a focus for public health, public policy organizations. But recently, sort of in the last sort of 10 years, there's been this growing interest from national healthcare organizations in addressing food and other social needs as a routine part of care in clinical settings or by health systems. Now, the first sort of national organization that came out with this was the American Academy of Pediatrics in 2015, when they recommended that all pediatric providers should screen and assist families that are presenting for well child care with food and other unmet social needs. Now, since that time, there have been several other national healthcare organizations, so the American College of Obstetrics and Gynecology, the American College of Physicians, that have all come out with their own policy statements recommending that healthcare providers, health systems should consider assessing their patients for unmet needs, as well as trying to assist them in some way. And most recently, the Center for Medicare and Medicaid, as well as the Joint Commission that manages hospitals, have come out now with requirements as of January of 2024, requiring that all adult patients admitted to the hospital be screened for 5 social needs. So that's food, housing, transportation, utilities, and intimate partner safety. Now, the idea, I think, from CMS was that they would tie social needs screening with reimbursement so that hospital systems would have to do this, and then eventually sort of expand to pediatric populations as well as outpatient settings. It's a little unclear what's going to happen in the current state of the world that we live in now in the US about what's going to happen with these requirements. Currently, they're still there, but it's unclear if they will continue to be in the next round of sort of revisions to CMS or not, and what that will mean. But I'm assuming the hospital here is already screening for health-related social needs. I'm assuming lots of health systems, including ours, are sort of like trying to figure out like how do we actually implement this. So with this sort of focus, I think that this kind of raises 2 questions that if healthcare settings and clinical care settings are going to start trying to assess patients for social needs and assist them with food. The 2 key questions are, 1, how can you effectively and equitably identify which patients are food insecure? And then what can you really do in a clinical setting when you've identified a patient is food insecure? So we'll start with the first question: how do you actually assess patients? Because historically, physicians, nurse practitioners, nurses, clinics haven't done this. My patient DB, it wasn't that I sort of had thought to assess him or screen him in some systematic way. It's that the mom just sort of organically brought it up. So how do we sort of implement sort of ways to systematically assess patients in sort of a family-centered, patient-centered approach? And what can we even do to do that? So this study was published a few years ago that looked specifically at brief, validated questionnaires that had been used in healthcare settings to identify patients who are food insecure. And what you can see, they screened over 1,300 titles, reviewed 190 papers, and identified sort of 3 brief, validated questionnaires that had actually been tested in healthcare settings to screen patients for food insecurity. And so these are the 3 questionnaires. The one that's become probably the most popular is the 2-item hunger vital sign, probably because many of the electronic health records have now included this or embedded these 2-item questionnaire within the electronic health record. So if you use Epic, it's what's in Epic. But basically, it asks patients within the past 12 months, we worried whether our food would run out before we got money to buy more. And within the past 12 months, the food we bought just didn't last and we didn't have money to get more. And a response to often true or sometimes true to either question is considered a positive screen. And compared to that 18-item USDA food security survey module that I mentioned, it's been shown to have 97% sensitivity and 83% specificity. So it looks like we do have some availability of some brief questionnaires that people could use in their clinical care settings to identify and sort of systematically screen all patients for food insecurity. But it turns out that not just picking the right tool or picking the tool that works best for the clinic is what matters. It also matters how you ask these questions. So this is a study we published a few years ago that took advantage of a natural experiment that happened in one of our pediatric primary care clinics. So the clinic had actually been screening for food insecurity using that 2-item questionnaire since about 2013. And what they started with was that they would have the provider, either the physician, the nurse practitioner, verbally ask patients during the visit those 2-item questionnaire. And then beginning in January of 2018, they decided they wanted to try to move to a written-based questionnaire just to kind of help with workflow, that they were worried that maybe people weren't completing it correctly or people weren't really asking the questions. And so we did an interrupted time series analysis just looking at how did the rates of positive responses to the food insecurity questions change just by switching from a verbal to a written-based questionnaire. And what you can see, when it was being verbally asked, about 10% of patients who responded reported being food insecure. And then there was this kind of significant jump to around 16% just by changing to that written-based questionnaire. Now, interesting enough, when we published that study, there was another study that just had gotten published around the same time from the Children's Hospital of Philadelphia, where they actually randomized families to screen in different ways. So they randomized families that were presenting to their emergency department to either get a verbal questionnaire from the MA or nurse, asking that 2-item questionnaire, or the families had a tablet, either in English or Spanish, that asked those questionnaires. And again, they kind of had a similar experience where if patients were screened with the tablet, about 24% reported being food insecure, compared to about 18% who were verbally asked. And there's been some sort of subsequent qualitative studies kind of looking about why that matters and how you screen matters. And it's probably not surprising to a lot of people in the room that when you sort of verbally ask these questions, they're sensitive, particularly for parents. They're already worried that if they sort of tell you that they're struggling with food, it could lead to, a CPS report or someone trying to take away their children. But by sort of verbally asking, a lot of parents reported in qualitative studies is they felt like sort of some surprise and a lot of shame about being asked these questions. And so they didn't always feel comfortable telling the healthcare provider that, yes, I worry about being able to feed my kids. But for some reason, doing it on like a written-based questionnaire or a tablet made it feel a little bit more anonymous. And so they were a little less, a little more comfortable sort of responding yes in those situations. There's also, particularly again, for parents, having children in the room. And so, they're trying to protect their children from finding out that, hey, yes, we're worried about having enough food at home, particularly young children in the room. And so, again, sort of verbally asking sort of made people a little bit more uncomfortable. So again, I think this kind of gets at like, not just picking the right tool, but how you implement the tool does matter. So again, the second big question, I think, is, so what can you really do in a healthcare setting? Again, health systems, clinics haven't really taken on providing social services or providing food to families. So in 2022, the White House actually held the first sort of national conference on food insecurity in 50 years. And one of the main pillars that emerged from that conference was this idea of better integrating nutrition in healthcare settings, particularly in advocating for what has been called food as medicine, or the provision of healthy food either to prevent, treat, or manage diet-sensitive chronic conditions that is provided in healthcare settings and actually paid for by healthcare settings. Now, food as medicine has kind of taken on sort of two sort of broad categories. The first are what are called cash-like benefits. So this is kind of how the SNAP and WIC benefits that I mentioned work. So you essentially provide patients or families vouchers or subsidies in order to subsidize the cost of healthier foods like fruits and vegetables. One sort of intervention that has kind of taken on this sort of similar process is something called produce prescription programs. So essentially, if you identify a family that's food insecure, you can provide a voucher that they can use at a local farmer's market, local grocery store, in order to sort of purchase or provide free fruits and vegetables for that cost. The second sort of broad category has been called in-kind benefits. This is where the healthcare or the research team actually selects the foods and directly provides the provision of foods to patients and families. And often these are designed by a registered dietitian. And this is taken on the form of sort of medically tailored groceries or medically tailored meals. Again, where the dietitian sort of designs the meals based on sort of a chronic condition. And then these meals are directly delivered to households oftentimes in order to sort of help and manage chronic conditions. So I will say that the data around the impact of these different sort of food as medicine interventions is still growing. So I won't pretend like that we have all the answers at this point. And a lot of the studies so far have been primarily in adults with chronic conditions. But there have been some studies in both pediatric populations and among pregnant patients that I was going to mention in particular for today. So the first was this narrative review that was published about 2 years ago, year and a half ago, that specifically looked at food as medicine interventions among pediatric populations. Now, I'll just say they didn't include federal nutrition programs because both SNAP and WIC have sort of a pretty broad evidence base showing their impact on both reducing food insecurity as well as improving health outcomes. So they really just focus on sort of these three new sort of modalities of food as medicine. So produce prescriptions, medically tailored groceries, and medically tailored meals. And again, there are not a lot of studies out there, but the studies that are there are starting to show some promise. So particularly for produce prescriptions in pediatric populations, it does look like they do reduce food insecurity and improve produce intake. Their impact on health outcomes is a little bit mixed, and they've primarily looked at BMI for the most part. But again, these are sort of smaller studies, and so may show some improvement in health outcomes for produce prescriptions. Medically tailored groceries and medically tailored meals, there's even fewer studies. So there were 2 studies focused on medically tailored groceries and 1 sort of feasibility study looking at medically tailored meals. Again, this was just looking at, can you feasibly provide meals to households? And it focused on patients that were discharged from the hospital. Yeah.
Just a question about how these were funded. Are these research type programs that are funded through a research mechanism, or is this coming from the healthcare system as a redirect of some of the profits?
Yeah, how do you fund these things? Yeah, that's a great question. So most of these were all research studies. So I think they're primarily grant funding. I do know they got this study right here. They did get some support from their health system to do it, but they also got a grant. Just because I know the research team, I know they got a grant from Kroger to do part of it, and then the health system chipped in some too. And that's the unfortunate reality, that a lot of these programs have primarily been sort of grant funded programs and to test them. There is some increasing, or at least there was some like enthusiasm, motivation from different insurers. So Medicaid in particular has had a couple of different pilot programs and still does as part of their Medicaid 1115 waiver. I know a lot of the people in the audience do Medicaid, so I'll try not to butcher this too much. But basically that they were using, a lot of the several states were starting to use Medicaid 1115 waivers to support doing different food as medicine interventions. And how are we doing on times here? I think I can get to that. So I do have a slide looking at North Carolina's experience with it that I think we should have time at the end that I can come to. But you're right. Most of these have been grant supported, kind of testing them out. And the same thing, again, this review that looked specifically among pregnant individuals, similarly, the sort of 5 studies that they included in this systematic review were all sort of grant-funded research projects. And again, like I said, there were only 5 studies in this review, so hard to take a whole lot of stuff from it, but does seem to show some promise, particularly, again, they did find that particularly among produce prescription programs, they did see this kind of, again, reduced food insecurity, increased produce intake, and maybe some improvement in maternal stress as well as preterm birth rates. Unfortunately, there's only like 1 or 2 studies for medically tailored groceries and medically tailored meals. But again, both of them seem to show some promise. But again, I think we'll need some larger studies to specifically look at the effectiveness of them. So I can pause there and take other questions about this, or in the sort of last few minutes, I was going to talk about one of our sort of new approaches that we're taking to food as medicine. And I'll admit, this is a new approach. And so we just started doing this study. So I actually welcome feedback and thoughts on it as we're sort of trying to like kind of grow this kind of area that focuses on. So as I mentioned, sort of a lot of the food as medicine studies have kind of been sort of these research studies that focused on one particular intervention. So they focused on the impact of produce prescriptions, or they focused on the impact of medically tailored meals. But actually, food as medicine proponents actually recommend sort of more of a tiered approach to providing these different food as medicine interventions, primarily because of the cost. So medically tailored meals are particularly expensive. If you think about, you have to design the meal, you have to make the meal, and you have to deliver the meal to people's homes. Whereas produce prescriptions may be a little less costly in most situations. You know, you provide a $10 or $20 a week voucher for patients. And so again, that's why this sort of pyramid was sort of designed the way it was to sort of think about like, well, at baseline, all patients should get some of this sort of assistance with signing up for federal nutrition programs, and to try to reserve the more costly, like medically tailored meals for those who are sicker or more in need. But it's kind of hard to kind of design sort of a health system approach to doing this kind of tiered approach just simply based on sort of the traditional RCT. So we're actually doing kind of what's called a step care approach and testing that now to see if we can do this sort of almost tiered approach to providing food as medicine interventions within a health system or within several clinics, actually. And kind of this step care approach is kind of how we practice medicine. So for those that are familiar with the asthma guidelines for pediatrics, like again, they sort of provide a kind of a stepped care approach to sort of asthma management. So again, those that are sort of less sick, you start with sort of a low dose inhaled corticosteroid. But for kids that are more in need or have higher symptom burden, you sort of step up to using sort of a higher dose inhaled corticosteroid or adding 2 or 3 different inhalers. And so we're actually trying this with food, like a food as medicine approach. So we are partnering now with several different of our local organizations in Winston-Salem. So our local WIC department, as well as Hope of Winston-Salem, which is a local nonprofit that does produce delivery to different neighborhoods across Winston-Salem, as well as Second Harvest Food Bank, which is our sort of large, sort of the main food bank for our 18-county region. And Second Harvest Food Bank actually invested in trying to develop their own medically tailored meals program, where they actually have a registered dietitian on staff. They design the meals based on input from the community. They make the meals there, and they actually have invested in hiring drivers as well as a whole sort of delivery system so that they're able to actually take it to patients' homes. So we've been fortunate that we can actually partner with these 3 groups to try to test this kind of step care approach. So to do that, we're using what's called a sequential multiple assignment randomized trial design, so a SMART design. You all actually might be more familiar with SMART designs than most audience I've talked to, because a lot of the people that do SMART designs are at the University of Michigan. So I relied heavily on their published literature when we were sort of talking about this study. But this is what a SMART design looks like. So yes, I know, super easy to follow and not complicated in any way. But to walk you through, what we're doing is, so we are recruiting from 3 of our OB clinics in the Wake Health system, pregnant individuals who report being food insecure. So these 3 clinics had sort of systematically implemented food insecurity screening as part of their sort of initial intake visit for all OB patients. And so as just sort of routine care, they screen everybody that presents for that sort of new visit. And so we're recruiting patients who are pregnant in their first trimester who report being food insecure. And then we randomize for one of 2 first stage interventions. So the first, so they can randomize to either being referred through our electronic health record to WIC or the EHR WIC referral plus care navigation. Now, 2 of my collaborators on this study actually developed a process in our electronic health record where we're actually able to send referrals directly to WIC for patients. And WIC has actually read-only access to our electronic health record. So the providers are actually able to just to send a very sort of like the same thing you would do if you're ordering a medication or ordering a consult. Basically, we can send the same sort of use that same sort of method to refer someone who might be eligible to the WIC program. They directly receive the WIC referral, and then they're able to refer, to respond back to us and say, "Hey, we met with Mrs. X, signed her up for WIC." So patients get referred to either just a referral or a referral plus a care navigator who meets with them at the sort of baseline visit, and then follows up within 2 weeks to say, "Hey, were you able to meet with the WIC program? Did you have any issues with getting to the appointment? Did you have any issues with like the paperwork that they required?" Again, to kind of provide sort of another level of support. So then we follow up all our participants at 3 months. If their food insecurity decreased, we're like, "Great, we'll follow you back at 6 months at the time of sort of delivery or post-delivery." Again, looking at food insecurity, looking at some health outcomes, as well as sort of maternal and infant outcomes. So, did they have preeclampsia during the pregnancy, preterm birth, things like that. For those that didn't have an improvement in food insecurity,
Sorry, just one quick question. The definition of food insecurity you showed before was within the last 12 months, have you blank? But here at 3 months, how can you know if the question is the same and they're still saying within the last 12 months?
That's a great question. So the primary way that people use it is in the 12-month questionnaire. USDA actually has a 30-day questionnaire. So we're using the 30-day questionnaire for this study. Yeah, you're actually the first person to kind of point that out. But yeah, so we're specifically having to use the USDA 30-day questionnaire. So it asks the same questions, but asks it in a different time frame. And we had to use not just a 2-item questionnaire for this. We're using the full 10-item questionnaire. Well, we're using the full 18-item questionnaire to do sort of looking at differences, because we are sort of trying to do that difference parts. That's a great question. So for participants who don't have an improvement in food insecurity at the 3-month mark, we re-randomize them to either get produce prescriptions or the medically tailored meals. The produce is provided by our partner, Hope of Winston-Salem. Again, they get sort of $10 worth of produce. We're actually delivering it to their house for this study. So $10 worth of produce delivered each week for 3 months. Or they can get medically tailored meals delivered to their home. So they'll get 10 meals, 5 lunches, 5 dinners that they can sort of heat with, stove, microwave, oven. And they'll receive that weekly for 3 months. Same thing, we're going to follow them up at 6 months, again, to look at changes in food insecurity, as well as some of those maternal infant health outcomes. This is great.
Sorry, the medically tailored meals, is that just for the pregnant woman, or is that for the entire household?
So for this study, we're doing it just for the pregnant woman. You bring up a great point. What do you do for the rest of the family? So
produce could be for the whole family.
Exactly, yeah.
Does the questionnaire talk about the family or the individual?
The food insecurity one, or the which one? Yeah, so the food insecurity asks about the household. Now, the first 10 questions of the 18-item questionnaire are focused on the adult, and then the last 8 questions are focused on children in the home. Because we're like recruiting women that may or may not already have a kid in the home, we're sort of focusing on the adult for this study. We're doing another study now with, we're providing family meals for patients discharged from the hospital. That one's getting food for the whole household. But yeah, that's a great question about like what you do for the other people in the home.
Just because that obviously could impact the impact of the medically tailored meals versus produce.
Yeah, which one do you do for this population? Yeah.
So this is more of a conceptual question, but you said that the produce prescriptions are cash-like, right? Mm-hmm. So begs kind of the question, why not just give cash? Why not essentially give people $20? I know
ask him.
Yeah. I mean, it really gets at this question of like, really what we're trying to do with these programs is it's redistribute income. Right? Mm-hmm. Essentially trying to address society's like failure to ensure that people are not in poverty.
Yeah.
So I almost wonder in a different version of this, instead of MTM being the other arm, it almost makes me wonder like equivalent value of cash in your hand, equivalent to what the produce prescription would have been worth. Yeah. Right? It just makes you wonder whether that might have been more effective, less effective, who knows, right?
Yeah, no, I'm 100% with you on this one. And actually I was going to ask Sumit about it at lunch today. We could do the next iteration of this study with just giving out cash. I'll say we ended up doing food for a couple reasons. One, this was NIH funded. So we were like, I think NIH will probably more go for the food if they think it's food. So that was part of the reasoning behind it. And we wanted, again, sort of this like, which food is medicine intervention do you provide for families was part of the other question. Getting to the point of like, we are doing food consumption diaries as part of this study to see like how much food sharing is there, or is it just the person involved in the study?
And one of the issues with unrestricted cash, if in fact it is unrestricted, is you have no idea how people, maybe it's going to be on that nice pair of tennis shoes or, like whatever. It's not necessarily, because that's, or not necessarily healthy foods. If the goal of this is well, it depends. Is the goal to decrease food insecurity, or is the goal to, is it also to increase healthy eating?
Yeah.
Because those may or may not be the same strategy for different families.
Very true. Yeah, that's a great point. I will say with unconditional cash transfers, and you can correct me if I'm wrong, Sumit, but for the most part, people do spend the money on basic needs, so food, housing, and transportation. So it's likely that they will spend it on something that like it might not be food, but it'll be something that like is important for the health of the family.
Just as a caveat, I know that there's some of the, and I guess this is state by state, that allows people to use SNAP or other monies either on non-healthy food products like Coke or ice cream, and others are not. There's more restrictions on WIC. Is that correct?
Yeah, WIC definitely has more restrictions than SNAP does. There's definitely been some like policy conversations around should they also restrict what you can use to purchase with SNAP. Primarily, the main restrictions on SNAP purchasing is you can't buy alcohol or cigarettes with it, and you can't buy hot meals with it.
Right, but you could buy ice cream.
You technically could buy ice cream with it, yes. So again, getting to your point, like what do people spend their sort of cash allotment on? Yeah, but WIC is definitely much more restrictive on what you can buy.
This is just so interesting.
Oh,
The whole question of whether it's unrestricted funds, there are studies with that happening now, right? Like in Flint and Detroit, they're giving $500,
Yeah.
I think, to mothers of children between birth and a year. And it looks like it's having positive outcomes on health. So I don't know what they're buying, but there seems to be some benefit there to just the unrestricted funds.
Absolutely. And then Sumit, you did your study in Chelsea, is that right? That was the Chelsea study where they did it again with pregnant mothers and again had positive effects on, I can't remember all the birth outcomes. You might.
There are no birth outcomes.
There were no birth outcomes, but it was maternal stress and.
It was ED visits for.
Okay. Okay.
But I'm helping with RX Kids research too, and we are seeing big improvements in food insecurity.
So that's great. Yeah. So I think it kind of comes down to one of the nice things with the design is we can kind of, plug and chug different possibilities of what we think you can provide. And it ends up creating, yeah.
Like relationships with the grocery stores.
Mm-hmm.
Like a lot of people sees that like produce is so expensive compared to like, like a box of food or
Yeah.
anything. Is there any negotiations with like maybe at cost or reduced price so they could I mean, like at my grocery store, a bag of apples could be like $7.
Yeah.
Giving somebody $10, like that's not very much that they get. So is there negotiations with like at cost or reduced or just like product amounts that they could get versus like $1?
Yeah, that's a great question. I'm not sure of anybody that's specifically focusing on that. I know that Instacart was very interested, particularly once the pandemic hit, in trying to assist with sort of getting people access to foods and healthier foods. And they were doing some stuff around like subsidizing the cost as part of Instacart. I know they lobbied a lot around being allowed to use sort of WIC and SNAP benefits through Instacart. But I don't know, and other people in the room may know of things that like people like trying to negotiate with like, how do you just sort of get it at the source of like, how do you just reduce the cost of foods for everybody? Yeah. Yeah. No, that's a great question. Yeah, I don't know if anybody else in the room knows of anybody that's trying to negotiate that part. Yeah, that's a great question.
Where you shop makes a difference.
Where you shop makes a huge difference, and people don't necessarily. I mean, there have been some studies in was it Philadelphia and Wilmington, Delaware, where they tried to create sort of healthier supermarkets. And again, I don't think it didn't quite have the effect that they were hoping for it because people didn't want to leave the grocery store they were familiar with. So they didn't quite get to that. So Karen Glantz out of Penn did that where she, they designed sort of what they called a healthy grocery store where they tried to make the sort of healthier foods cheaper. They tried to do all this sort of choice architecture about making it easier for people to find. But they realized like it wasn't quite reaching the community they wanted to, that a lot of the people in the community with the grocery store ended up just going to the grocery store they had already been familiar with. I thought I saw a hand over here.
A little off topic.
Yeah,
So
yeah.
context is that I'm a pediatric pulmonologist, take care of a lot of kids with severe asthma, many of whom have food insecurity and nutritional issues on the end of the spectrum, very underweight and very overweight. And so we have a dietitian as part of our severe asthma clinic.
That's great.
A ton of what she winds up counseling on is picky eating and behavioral things in the preschool to early elementary, just like the kids won't try new foods, they don't like things. Sometimes that's there's a neurodivergent comorbidity, but it's like in those, the parents are honestly trying to diversify the diet and offer more fruits and vegetables, even in the food insecure households. But the kids won't touch the stuff. So they wind up on the chicken nugget, pizza, macaroni and cheese diet. So I realize I've taken you off topic, but how does the food insecure literature deal with that? And is there a strategy there?
So I don't know of any strategies to address it, but the issue you're talking about is talked about, that like families are particularly from food insecure households, are afraid to try to diversify the foods because they're like, well, I can't spend it on things that my kids aren't going to eat. Like, because then that's our money for the month. So if they don't eat it, then they're not going to eat it. I haven't seen anybody that actually has tested or developed a real strategy. I mean, I feel like it's kind of the classic sort of teaching is that like, picky kids, you try to offer as many different foods as you can. They have to try. You have to try like 7 times for them to something like exactly. But it's assuming that you can buy all these healthy foods and it's not going to be a huge issue. So I don't know if anybody else has seen anything in the literature about what do you do in that situation. I've just seen the whole point of like families are like, well, I can't, like, this is what we have. This is what I know he or she's going to eat. So this is what we're going to get. Yeah. This is so much fun. Yeah.
Really neat study design. I'm curious why you think some pregnant women will have suboptimal improvement. Is it because the referral doesn't link them to WIC, or they don't qualify for WIC, or that's not sufficient?
All three of those things. So I think it's come out. So I will say, so we've only we just started the study. So we recruited 26 people so far. About 40 to 45% seem to actually have an improvement, and 55 to 60% don't. My guess is many of the things that you're talking about, either they didn't qualify for WIC, they didn't, for whatever reason, decided not to try to get WIC. So we're just testing the referral. We're going to collect to see if they actually got WIC or not. But I think some people are a little bit hesitant, particularly in the current climate, to try to sign up for federal benefits. So one of the three we picked the 3 clinics we did because they're a little bit diverse in the populations they serve. One's very rural, and the other one serves a primarily Hispanic population that we don't ask, but I'm guessing there's a fair percentage who are undocumented, and so they probably are like, thanks for the referral, but I'm not going to follow up. And then I think also that there's probably a portion that like the WIC benefits are just not enough for what they need. So we're going to try to do some qualitative work at the end to kind of get it that you're talking about. So we've done 1 interview so far, so I can't give you much on that one. Yeah.
This is just my own personal philosophy. So I'm always wary of any sort of interventions that like make the healthcare system bigger and increase healthcare spending. Like if I were going to basically take 1% of US GDP to address food insecurity, I wouldn't shunt it through the healthcare system. I would use other kinds of approaches, right, that are probably less expensive and more efficient. And so I just wonder if you ever feel like you're not futility, but just almost like you're putting a Band-Aid on.
Yep.
You're almost like working on improving implementation of interventions through a system that probably has very little business in the first place of really dealing with this problem.
Yes. Should we really be punting social services to the most inefficient portion of the U.S. economy? Probably not. And again, that's why I always try to end with like, you know, a lot of this really just comes down to policy, and the policies that we have in place in order to lift up people in our society, and what are we choosing to spend our funds on. I heard, for those that know Mandy Cohen, she was the former CDC director. So half the mornings I wake up and like what you're talking about, I feel futility in what I do. The other half, I feel hope, because I think of I think of this quote that Mandy said. I'm probably totally butchering it. Basically, that she was like, we have to pull the levers that we can pull. And until you have sort of broader sort of political will, then, you know, this is what we can sort of make a change to help people in the short term. So yeah, so 50% of the time I'm depressed, 50% of the time I'm hopeful. So this morning I woke up hopeful. This is great. So this is super helpful for me, actually. Next week I'll be totally depressed about something. I threw out of time, but yeah, I just wanted to say that yes, this is what you get. Your question gets it. Like, it really comes down to policy. Yeah. Awesome.
That's a great note to finish on.
Yes, this is great. Thank you.